Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center. Hope you're having a great day. This is an open mics program. We're back with me, Dr. Stites. Today we're looking at how far we've come in treating multiple myeloma. It's the third leading blood cancer. When I started in medicine, it was a deadly disease. Today, the American Cancer Society reports that 1 in 132 people are at risk of getting multiple myeloma in their lifetime, with seniors being the most at risk. And the blood cancer develops when plasma cells in the bone marrow multiply uncontrollably. Today's guest is currently showing no signs of cancer thanks to one of the most cutting-edge treatments in oncology, CAR T-cell therapy. It represents real hope, and sometimes we can call it a cure. Sherry Kennedy, a longtime University of Kansas Cancer Center employee, once helped patients fight cancer until she became a patient. Today, she shares her remarkable 17-year journey from diagnosis to remission.
It began in 2007, a strange feeling at work Sherry Kennedy couldn't explain.
I couldn't use my left hand, and a couple of months later found out there was a big tumor there eating on my bone.
Tests confirm multiple myeloma, a rare blood cancer.
What in the world is that?
Sherry started treatment, radiation, chemotherapy, and later a stem cell transplant.
They say it's going to make you really sick, we're going to almost kill you, and then we give you your cells back.
After brief remission, the cancer returned 4 times. By 2021, the doctors at the University of Kansas Cancer Center recommended something new, CAR T-cell therapy.
If an 11-year-old with leukemia can do it, you can do it.
Dr. Roy Jensen, who worked with Sherry for years, says her case came at a turning point for cancer research.
She received CAR T pretty early on. The early results had been so incredible. That trepidation was largely replaced with kind of relief and hope that we would have something that would really be able to make a difference.
Now, nearly 4 years later, Sherry's in complete remission. No infusions, just labs.
It made me able to sit here and talk to you today and tell you about it.
She credits science, faith, and never losing hope.
Find a specialist, make sure you have support, and don't lose hope. Hope is always out there.
Sherry Kennedy is joining me in studio today, along with 2 blood and bone marrow transplant experts. Dr. Joseph McGurk is the Director of Hematologic Malignancies and Cellular Therapeutics at the University of Kansas Cancer Center. Also, Dr. Alaola Abdallah, a multiple myeloma specialist in hematology and the Medical Director of Plasma Cancers. Gentlemen, welcome back to the program today. Sherry, you shared that you never lost hope. How did you stay so positive and so motivated?
Well, I had great support from my family. My daughter, my sister, and the staff at the Cancer Center was very supportive.
Yeah, that's a really big deal. And having that new treatment, so talk to us a little bit about that. Dr. McGurk, rare blood cancer, well, tell us the story.
Yes, absolutely. It affects about 13,000 people a year in the United States. And it's a terrible, devastating disease historically, attacking the bones, as Sherry mentioned, forming tumors in the bones, and sometimes in organs the tumors can form. They fill up the bone marrow with a bunch of cancer cells, can cause terrible, debilitating pain, kidney damage, and ultimately bring about the demise of our patients. Historically, when I started out in the field, median survival was 2 years. Game changer, completely different story today.
It is a different story. And Sherry, you worked with a friend and colleague of ours who we just saw in the video. Dr. Roy Jensen is the Director of the University of Kansas Cancer Center. What was your role in the cancer program?
Oh, my first job was one of my favorite jobs in my life. I worked for Roy and really learned a lot about just cancer, how to spell some of the diseases too. Then I transitioned to the clinical trials office, learned a lot about that, learned how to spell a lot of the diseases too. So
you know, that spelling thing is kind of a challenge because these guys keep changing the spelling and they keep changing the names. And like there's like Lucy in the football with Charlie Brown, you know what I'm saying? Now, Dr. Jensen couldn't join us today, but we asked him about when he found out you were diagnosed.
Our reality is that we take care of somewhere between 7,000 to 8,000 new cancer patients a year. And so it's those figures are almost mind-numbing. And but what kind of jolts you into reality frequently is when someone who's been part of the family, has been part of the inner circle for literally years, you know, they come down with a diagnosis. And, you know, and it does set you back, but on the other hand, we understand that there's no better place for them to be. And, you know, things have changed dramatically over the last 20 years in terms of the therapies that we offer and the effectiveness of those therapies. And so it's great to be able to offer hope to any of our patients. But obviously there's something special about, you know, somebody who's been part of the family.
You know, that's a pretty good testimonial, and just to say it means you've got your foreign language certificate and all these names we have, and can spell and say it. Well, speaking of those new therapies, Dr. Abdallah, you convinced Sherry to undergo CAR-T therapy. It's one of the biggest developments in cancer treatment in decades. The University of Kansas Cancer Center was the first and only site in the region to offer, now I'm not going to say this, so you have to say it. What's the word?
Oh.
This word,
Abecma.
Okay, CAR-T cell therapy to treat multiple myeloma. And so tell us a little bit more about that and some of these words that we
Absolutely. And we have to understand exactly this really is a very important development of CAR-T cell. And Dr. McGurk, you know, have been actually one of the first pioneers in KU to bring the CAR-T cell prior to the myeloma to acute leukemia and lymphoma. And I think the importance about that is that we are redirecting ourselves to change how we treat myeloma to immunotherapy. So taking your T cells and putting what we call a CAR, or I call it a laser tag, that we target the myeloma cells. In our myeloma cells, we have a target called BCMA, which is present in 95% of the times. So that is a very important thing, you know, for this CAR-T cell to recognize these myeloma cells. After we, you know, make or manufacture these CAR-T cells and make millions of that, we reintroduce it to the patient after we give a small dose of chemotherapies over 3 days, and these CAR-T will go to the to the body. Wherever there is a myeloma, it will attach to it, and like any other T cells that attacks the infection or any cancers, if they find it, it will produce cytokines, and I call it like bullets. Will attack the myeloma cells, kill the myeloma. The response rate of the CAR-T cell, and Dr. McGurk can agree about that, is really amazing. You're talking about one single treatment for patients who receive multiple lines of therapy was over 80–85%, you know, in a very high dose. And that was very impressive because we're not talking about just response rate. We're talking about a one-time treatment. So when we saw these results, we were very excited about it, especially like the historical results of prior to, you know, for standard care treatment or any drugs was barely 20–30%, and we moved to 80%. So that was a big and a huge jump using this CAR-T.
So let me get this right. You take the cells out, you reprogram them, you do something, and then they go play Stormtrooper and laser tag, and they kill the cancer, right?
Correct.
So really it's kind of like magic, only it's real, and we call it science. It's like it might have it right there, folks. All right, so why was this the right choice for Sherry? Tell us about what made her case in particularly amenable to it.
Absolutely. I mean, unfortunately, myeloma in the majority historically have been an incurable disease. It's like diabetes. Your myeloma is going to come back again. Every time you have a treatment, you know, you can go to remission, but you can't stay in remission every time. And that, you know, length of remission shortened down. So we really needed newer treatments, and the CAR-T cell came on the time that, you know, Sherry was actually relapsing, and she met the you know, the criteria for actually receiving the CAR-T cell. Newer treatment, and not only that, the quality of life that we talk to patients about it, because Sherry had been on multiple treatments. She had to receive the treatment either weekly or monthly coming to the cancer center. You're talking about a CAR-T cell treatment. Well, I mean, in the past it used to be inpatient, but Dr. McGurk and his team are able to do most of the treatment outpatient. So we're talking about a good quality of life for patients receiving one-time treatment. Do not have to come weekly to receive any IV drugs or any oral pills every time. So quality of life versus efficacy, these two were actually magical, you know, terms for patients like Sherry.
So let me just get this straight. You're giving Stormtroopers as an outpatient now?
Yes, absolutely, that's right. We have the infrastructure at University of Kansas Health System to be able to do that 24/7. We're there to back those patients up immediately.
Yeah, that is remarkable stuff. Now, Sherry, do you remember what this conversation was like and how Dr. Abdallah explained this treatment to you, and what did you think?
Well, to be honest, he worked really hard on me to push me into it, along with Dr. McGurk. And yeah, it was interesting. I didn't understand what he was going to do. I really didn't, and I love the science of it, but I didn't understand it. But he kept pushing and worked on me. And at that time, more things were happening with CAR T cell.
Okay.
Yes, it was very, very exciting. Very scary, but very exciting. But I do like what he said about quality of life.
Yes.
That's what I was after.
Yeah, and it sounds like you've achieved that and received that, right?
I have.
From this new thing, this magical therapy.
Magical, right.
It is. Dr. McGurk, you've said it's one of the most stunning advances you've seen in all your years of practicing medicine. I would agree. What's the future for CAR T look like?
It's an extraordinary future. You think just about multiple myeloma, to take a step back for a moment, as Dr. Abdallah was describing. We take patients who have failed every other therapy known, multiple myeloma, and in one of the studies with the longest follow-up, 98% overall response rate, 82% complete remissions, and now we have 5-year follow-up showing that a significant percentage of patients are still in complete remission, and many in our field, including me, and I think Dr. Abdallah, believe that that's a curative therapy. We've never seen these kind of results in any type of blood cancer that we've treated historically. But we have a lot of work to do yet. Not everybody responds, not everybody who responds stays in remission, and it can take a toll. There are toxicities associated with these therapies. So not only are we refining things in multiple myeloma patients and other types of blood cancers, but as you know, in our center, we're moving into solid tumors now with early clinical trials to start attacking a broad array of cancers.
So you're coming after cystic fibrosis next because, you know, my patients still could use a little more help with their disease.
I can't speak to that, but I can speak to autoimmune disorders and neuromuscular disorders that are part of the immune system. In our center, as you know, and around the nation and the international community, we are exploring CAR T cells in those settings and seeing some very promising early results.
What are some of the toxicities like?
When those CAR T cells attack, they attack, as Dr. Abdallah mentioned, when they attack the flu, and you have the flu, the reason you feel lousy isn't because of the flu virus itself, it's the immune system's response and all of these cytokines that attack that flu-infected cell. Same thing happens with cancer. So when you take CAR T cells and you give them to the patient, you infuse them into the patient's blood, they go after billions of cancer cells, and it can cause flu-like symptoms times 5.
Okay, so you're feeling kind of crummy, but only for a while. And
that's right.
Can you ever do CAR T cell therapy a second time?
It's a great question. And so for those patients who have relapsed, we have been doing different types of CAR T cells and seeing some remarkable results. Indeed, we're making a CAR T cell here at our institution in our laboratories that recognizes not just one target, like Dr. Abdallah mentioned, BCMA. Those cancer cells are smart and they can pull that molecule off their surface and become stealth, and the T cell can't see them. So our strategy is to target 3 different types of molecule. So if one disappears, we're still going to get it.
So I think my thing about stormtroopers is pretty accurate here.
I love it.
Dr. Jensen agrees. He says we are just at the beginning of the journey on what CAR T can do.
In many ways, CAR T has, in its early stages, has had even more success than, say, like chemotherapy. When it began back in the 1960s. And I think that what it reflects is the fact that we're beginning to leverage a lot of very basic science knowledge around how the immune system works. I think we're just beginning on that journey. And so it's almost surprising the amount of success that it's had already. And as we learn more and are better able to fine-tune this therapy, I think it's going to be revolutionizing cancer care for many different types of cancers, not just hematologic malignancies.
It is a pretty remarkable journey. Do you think you and I could take some of his hair?
I sure would
Oh
like
my
to.
God, he's got so much.
It's not fair.
No, what happened there? Okay, work on that one next. Right. So as we mentioned earlier, CAR T therapy has been called a miracle drug, and the success of the therapy so far is giving patients a newfound hope. And before CAR T therapy was an option, Sherry underwent radiation, followed by chemotherapy, and a stem cell transplant. Sherry did a tandem transplant, something that was considered aggressive, in 2007. A tandem transplant is when you receive 2 doses of high-dose chemotherapy, each course followed by an infusion of the patient's own healthy blood-forming stem cells. The treatments are given weeks or months apart, but are usually completed during a 6-month period. Dr. Abdallah, walk us through what's changed in treatment over the last 18 years. Do you still do these kind of tandem transplants? Why not just go right to CAR T?
That's a great question, and I think this is a very important thing to, as Dr. McGurk say, in 2 years survival to now over 15 to 18 years, and we're hoping that we're going to start seeing cure. The reason of this shift happened because we're changing the way we're thinking how we treat myeloma from traditional chemotherapy now to more targeted therapy, and now we have the cellular therapy. The last 5 years we have seen all the cellular therapies evolved, and we have seen approval 2 CAR T cells and 3 bispecific drugs. This is a very important thing for our team to understand exactly like how much that really helped us a lot in terms of like how to treat myeloma. Not only we're talking about keeping patient in remission, but also we'll talk about quality of life, because 2 tandem transplant, that's really tough, for patients. And we stopped doing that years ago because we have great treatments right now. We have immunotherapy treatments, and I think the replacement of the stem cell transplant happened very quickly. Now, we're talking about tandem transplant. Now, the big question is everybody's asking, and Dr. McGurk, we have a little bit more debate about that. Can CAR T cell replace transplant? We do have a clinical trial that want to compare between CAR T cell versus transplant in newly diagnosed myeloma. We do have to understand that transplant have been there for years and years. It has been impossible to beat it, but maybe CAR T cell this time with the newer event can actually do that. We will know that through the clinical trial. So off the clinical trial, we do not do a CAR T cell up front, but in clinical trials, we do have a clinical trial that we can actually compare transplant versus CAR T in newly diagnosed myeloma.
That is going to be so cool. Wow. What's going to win?
Yeah.
That's going to be therapy.
Yeah, that's going to be a big match.
It is going to be a good match. All right, so Dr. McGurk, over the last 2 decades, treatment results have improved considerably, largely because of a number of new myeloma drugs that have become available. CAR T therapy worked for Sherry, but maybe it is, but sometimes it's not the right choice. Who would benefit from CAR T? Who do you think would benefit from some of these newer medications, and are all these trials going to give us the answer?
So these new drugs are remarkable in and of themselves, as Dr. Abdallah was mentioning. We're seeing complete remissions with what we call novel drugs in combinations. And so the current standard of care in the United States is novel drugs followed by stem cell transplant followed by maintenance therapy with some of these novel drugs afterwards, and that's made remarkable progress. As Dr. Abdallah mentioned, our strategy currently is to challenge stem cell transplant. We never want to get completely wedded to any given technology. I'm a stem cell transplant doctor, but my focus and goal is to come up with the most effective therapy for patients. So CAR T cell therapy, and I predict it is going to replace stem cell transplant in the years to come. We have a ways to go, and we're conducting the studies now. And so the current strategy is upfront immunotherapies in different forms and new drugs, followed by stem cell transplant, followed by the maintenance therapy. I envision CAR T is going to supplant stem cell transplant. But the bigger question is, do we even need these novel drugs? Can CAR T cell therapy do this work up front as first-line therapy for patients with these diagnoses? And that is going to be explored over the next several years.
That is amazing. And Dr. Abdallah, multiple myeloma is incurable in most cases, but remission rates and survival have really improved. What research are you following that has you the most hopeful?
I think one of the research that Dr. McGurk already mentioned is multiple targeted. I think that's going to make a big change. And Dr. McGurk has mentioned about one of the studies, the long study, which is very impressive. In relapsed myeloma, we used to tell patients there's no way you can go to remission and stay in remission for above 2-3 years. You're lucky for that. We're talking about 5 years after one treatment, staying in remission in 30% of the patient. That's huge. That's really big, and that was a definition of cure in the myeloma field. And I think we can increase that percentage. And one of the theories I have is that, as Dr. McGurk will say, multiple targets. target, like not only the BCMA, maybe GPRC5D or maybe another one that can actually increase that targeted from curing myeloma in 30% up to 50%, which is still great. You know, you're talking about the patients that we used to tell them that your myeloma is definitely going to come back again. No, you have a chance that you can your myeloma can be cured. That's one of the research studies that I think it's going to be a major impact. The other one, which is, although it's earlier, we call the in vivo CAR T, and which means, like, you know, you don't need to take the CAR T out. You know, you just re-inject the virus, you know, and you have the CAR T built inside your body. So this is kind of like going to be huge because it's going to be an access and available for a lot of patients. And I think these two things are going to make a big impact in the CAR T world.
Yeah, that is amazing. Dr. McGurk, your thoughts?
As mentioned, doing what's called in vivo CAR T development. We just had a meeting at 7 a.m. this morning, and we are one of just 8 centers in the nation that are going to open a clinical trial doing just that, and that is injecting what we call the vector to get those genes into the T cells inside of the patient without having to take their cells out and manipulate them in the laboratory. Very early exploration, but it's really, it's gee whiz science, an extraordinarily promising future. You know, I've always been excited about cancer medicine and cancer therapeutics and the potential, but now at this stage of my life, this is by far the most exciting time of my entire career, and I think many, many hematologists, oncologists would tell you that that's the case.
How can you not have faith in science when you see the difference that you and I have had in our careers?
Absolutely.
How can people constantly say, I'm going to go try all this other alternative stuff, when you see that myeloma patients today are alive who yesterday died?
That's right.
I mean, it is a remarkable, you and I have been in medicine so long, and we were doing rotating tourniquets back when I started for heart failure, and just watching people have heart attacks and people with cystic fibrosis when I started, lived about 5 years. And now, it's so different. And it's science that's changed us.
Yes, absolutely.
Yeah, it's amazing. Okay, we're here to answer your questions. Send them using the links on your screen to YouTube, Facebook, or email the Medical News Network. All right, let's check in with Doc Hawk.
Yeah.
All right. There's a new nasal vaccine for bird flu.
Yeah.
Bird flu. Talk to us a little bit about that.
Yeah, I think we need a nasal vaccine for science misinformation and disinformation, really. So I'll start out by saying that, you know, avian influenza, so there are multiple types. Most recently, the H5N1 type has been circulating around the globe for the past couple years. We've really known about human infections really since the late 90s. That has occurred. There's been no real sustained human-to-human transmission, although there was a recent article just published that there has been silent human transmission, more than we know of, recently with this new H5N1 that has been circulating. But, you know, what do we do? What do we have for protections? Well, there are 3 licensed vaccines for protection. The U.S. has made stockpiles of those. Certainly know in one of those northern European countries, they were allowing some of their residents that were a high risk for it to be able to get vaccinated against H5N1. Recently in the news, however, there's been a new intranasal version of an H5N1 avian influenza virus vaccine that has been tested. Again, it is very early. There are still a lot of steps to make it to the market, make it available for people, but it is a very early phase 1 trial, just showing that it may have some efficacy, as we've seen some broad protection from this vaccine. So overall, I think it's too early to tell, but you know, we are working to create protection and protective methods against avian influenza in humans. Right now, luckily, there is no sustained human-to-human transmission, but we know that many cases can be fatal, so it is important, and there always is that potential for avian influenza to become the next pandemic. However, again, we've known about human infections really since the late 90s. It hasn't gotten there yet, but we always need to be vigilant in doing the investigations and looking, and also creating things that can protect us as humans, and this may be one of those things that can help protect us.
Pretty cool. Now, we've been looking at the benefits of COVID vaccination, and now there's a new analysis regarding teens and vaccinations.
Yeah.
Tell us about what that analysis shows, because I think it'd be kind of good news.
Yeah, this is another recent study that we have seen, and basically what it showed is that vaccination can lower teenagers' risk of developing long COVID. As we know, long COVID is a horrible disease that affects many millions of people every year, or every day actually, in their daily lives. So what this study showed is that the risk of long COVID in these teens can be up to 36% lower in those teens that were vaccinated versus the teens that were unvaccinated and got infected. And basically, long COVID is a chronic condition that can affect multiple organ systems. It has been studied even in our health system. We've done several shows about long COVID as well. But it can affect things like people having brain fog, just having weakness and feeling tired all the time, shortness of breath, muscle aches, joint aches, really many systems that can be affected. And so we know that, we want our children to be protected because, from the disease, but also those long-term effects as well.
Okay, there's another one that I think you've talked a little bit about adolescents 12 to 17, looked at some of those long COVID symptoms. Yeah. Anything else you want to add to that?
Yeah, what I would say is that overall the data from this most recent study was very important in the fact that it showed that unvaccinated patients, so patients that got infected and were unvaccinated, had a 20% chance of long COVID. However, if you were vaccinated, you had a 13% chance. So that is a significant drop in the risk of long COVID. In addition, it also showed that even for severe long COVID, you had a 30% reduction in the chance. And what we have on this graphic shows that how does the vaccine work? Well, the first little red box with the squiggly line up there shows, vaccination can help prevent infection and reduce the risk of infection for a short period of time after vaccination. Next, in that second red box down there with the squiggly line, we also showed that vaccine certainly helps in reducing the risk of severe symptoms of COVID, which is very good as well. Those two things can help overall reduce the risk. And then also the vaccine can help mitigate further inflammatory processes within the body, which may be one of the causes of long COVID as well. We are still trying to investigate the full nature and the mechanisms of long COVID, but it can work in a multifaceted way, getting the vaccine. And this goes to what we have been talking about really since early on after we learned about long COVID, Steve, and the fact that all of the studies really have shown anywhere from a 15 to 30% reduction in a person's likelihood or risk of getting long COVID. This is just one more piece of information, one more piece of data to help support the fact that vaccination does help reduce people's chances of getting long COVID, and that is a good thing.
All right, so Hawkeye, as you think about all this science and you think about the information about long COVID clearly being reduced with vaccination and not having all the terrible side effects that people have made up, what is our advice and your advice to parents?
Yeah, and I'll say my advice is to please get your children vaccinated, and I take that advice, and I've said this before. The reason I do get my children vaccinated against COVID because they are at low risk of severe disease, but the main reason is to help reduce their risk of long COVID so that they can get through their days, they can play, feel well, do their schoolwork, and not have the risk of having those long COVID symptoms in their everyday lives.
All right, we know many of you have questions. Let's head to Studio B. Alexis, good morning.
Good morning, Dr. Stites. We have a great question from Jeremy Yenser. Jeremy wants to know, currently CAR T is using the patient's own cells, so is there any possibility that there could be universal CAR T cells from donors?
Ooh, that's an interesting question. All right, guys.
That's a great question. And so we are actually conducting such studies and looking at what we call off-the-shelf CAR T. Well, some of the things we've discovered about why not everybody responds, not everybody who responds stays in remission, is because the T cells in the patient who developed cancer, well, they developed cancer in the first place. T cells are supposed to prevent that. And so are they the best and healthiest T cells? And then in addition, as we mentioned, patients like Sherry who've received many different types of therapy, those therapies are not just toxic to cancer cells, they're toxic to the immune system and T cells as well. And so would it be better to use an 18 or 19-year-old college student to donate T cells and gene edit those so that they would not cause problems in our patient or be promptly rejected. And there are such studies. We've presented data nationally and internationally at meetings and such studies that we've conducted in different types of blood cancers. And we actually are forming a large network of centers throughout the Midwestern part of the nation under Dr. Gary Doolittle, the Midwest Cancer Alliance, that organization, to use off-the-shelf CAR T cells, which we can get the next day and not take weeks to manufacture, as was in the case for Sherry. Have them in 24 hours and take them out to our community affiliated centers and deliver the CAR T cells locally to improve access for patients in need. Great question. It is cutting edge. It's exactly what we're doing now.
Lori has a question. Lori wants to know, are there risks associated with CAR T therapy, and if so, what are they?
Most certainly there are risks. The patients receive chemotherapy beforehand. It's really just to suppress the immune system, not to treat the cancer. So the T cells will expand when we infuse them into the patient. That chemotherapy can cause low blood counts. We have to be mindful of that for some time period. They generally recover several weeks after the CAR T cells have been infused. When the CAR T cells are infused and they attack the cancer, they can cause significant flu-like symptoms, which of 95% of are very manageable with the therapies that we have to dampen down the immune system temporarily. But 5% of those patients can end up having to spend some time in the intensive care unit, and very rarely there have been fatalities associated with toxicities of CAR T, particularly in the early years of the development of these therapies. There can be neurological abnormalities that occur, transient, short-lived for our patients, because these T cells go into the central nervous system around the brain, the spinal cord, which is a good thing because cancer cells can hide out there. But when you get inflammation in those areas, it can be very challenging for our patients. Those are the principal toxicities that we contend with, but we have the infrastructure and the team 24/7, and all of our consultants in the institution who are very adept at handling those toxicities.
Jill has a question for Sherry. So Sherry, this one is for you. She wants to know if you got super sick during the treatment like they said you would, or how you felt during the treatment.
Oh, during CAR T, not really. The chemo I took before was a little challenging, but I was in hospital and I had great staff, Unit 41, 42, fabulous people, fabulous. And then I did get sick after that a little bit, got that high fever, and I did take that drug, ketamine, but it helped. It helped, yes. And a few days later I went home.
So, Dr. Abdullah, one quick question for you. How many folks have you treated now with this CAR T therapy?
Myeloma? That's a great question. I really need to look exactly and see how many, but I think it's like, how many we have CAR T? 600.
Yeah.
Really?
Yeah,
That's great.
We're one of the largest centers in the nation.
Yeah, that's a big deal. And those are 600 people who have a chance to live
Yes,
that
sir.
without science would not have lived. I'm going to do on my really thing. I'm going to invent a new word. INSI. Don't listen to internet science. INSI is not real science.
I like it.
Listen to the people who actually do the science. All right, this has been a great discussion. I'm grateful for our guests for being here. I want to hear final thoughts before we go. Dr. Jensen couldn't be here today, but Sherry, he did want to share this message with you.
Oh.
Everybody in the Cancer Center obviously, celebrates, her success, and we're so, grateful that we could offer her, some hope, and that hope is now translated into something that was probably far beyond any of our expectations at the time, and that's such a fantastic feeling.
Oh, that's powerful, Sherry.
That's really nice. It's very nice, yeah.
All right, Dr. Abdullah.
Well, I mean, I think, we have, a few things to say about that. Always remember clinical trials are the reason why we're right now here, So we encourage a lot of patients, to ask about clinical trials with your oncologist, and to reach out to KU Cancer Center. We have a really great office. We have great trials. Dr. McGurk is bringing the, world-class trials. We're not talking about any kind of trials, and that's very important.
All right, Dr. McGurk.
Yes, so absolutely clinical trials. And get yourself to a comprehensive cancer center like that at University of Kansas Cancer Center. You will be treated by folks who are very, very focused on specific types of cancers, who have an array of clinical trials that will be available to you and are cutting edge. You'll know you're getting the right therapy and you're under the best care possible. Absolutely essential. This is an extraordinarily promising time, but you got to get yourselves educated about the options.
You know, I love to say it, faith, hope, and science. Each of those is very powerful. The faith in science to help us get better. The hope that the research is going to take us to a different place. And the fact that science can deliver. Not the science you read on the internet, but the real science being done by scientists who have taken a disease that had almost 100% mortality rate, and today is a treatable disease in the long run, and maybe we can almost say the word cure. Faith, hope, and science allows us to live long and prosper. We'll see you next week.
She says taking GLP-1 medication for weight loss drastically improved her heart health. I'm Alexis Del Cid on the next All Things Heart. The patient, who also happens to be a nurse here at the health system, shares her journey through love, loss, and the person who inspired her to make this change. Thursday at 8 a.m.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.